Well, let's go ahead and get started. We're so happy to have you all with us today. Um, this is the PATHS presentation, and PATHS stands for Providing Accessible Training and Home Supports for Parents with Intellectual Disabilities. This is a second iteration of these trainings, and our session today will be about awareness and basic knowledge of intellectual disability. And we are a team here at the Institute for Human Development at NAU. And we are hoping to make these trainings meaningful and sorry, let me manage the participants. I'm gonna and helpful for everybody. And first thing we're gonna do, and obviously I'm needing to figure some things out as I go along here, my apologies, is introduce ourselves, and then we'll get to our presentation. So first of all, I'd like to introduce myself. My name is Sarah Clancy, and I am on the PATHS project here at the Institute for Human Development. And we're going to be joined by a few others today that we'll introduce in a second, but I wanted to take a second to thank and show gratitude to all of the people behind the scenes that have been able to help us with this. Those on our team from the Institute for Human Development at Northern Arizona. We're getting funding to do this from the Arizona Developmental Disabilities Planning Council. So we're really appreciative to them. Also, we have two advisory boards. One is made up of home visiting supervisors. So maybe that's how you heard about these trainings. The other board is made up of parents who have intellectual disabilities, and they've helped us with our slides and our presentations and our content. And then previously we had been interviewing home visitors and just kind of learning more about what they know about intellectual disabilities and parents with intellectual disabilities, and are excited to be using that information in these trainings now. So the rest of our team here at NAU, you know myself. Nicole Rambo is the co-presenter today, and she is sorry, hold on. An occupational therapist who has practiced in early intervention in both Northern Arizona and then on the Navajo Nation too. Michelle Lee is an evaluator on our team. Glad we're getting some new attendees. Greta is a research assistant with us. Unfortunately, she's not able to be here. Maggie is here. She's one of our students that are helping the project. And then Nicole and Alex do a lot of great work behind the scenes. I'd also want to introduce you to our other co-presenter today, Krista Howard. She is a mom she lives in Phoenix. She has a 13-year-old son, and they love to ride bikes together. She is studying to be a speech language pathologist assistant, and she is going to be using a communication device throughout the presentation today. So we're really excited to get to have her to present with us today. So about that, I will turn it over to Nicole and Krista.
Awesome. Thank you. Next slide.
Right.
Yeah, great. So we're going to dive into more of a learning session, and here are our learning objectives. So today we have 5 items that we'd like you to learn and take away from this session. First, we'd like for you to see the use of person first language and plain language. We'd like you to describe defining features of intellectual disability or ID. We would like you to be able to name common myths about parents with ID. We would like you to understand common challenges faced by parents with ID, and also to begin to identify strategies that you can use when working with parents with ID and their children. This training is really geared towards home visiting programs and home visitors. And so that's the lens that I'll be using to kind of talk through. This is a small group, so feel free to use the chat to ask questions or to use the raise your hand function. We'd be happy to answer questions throughout the slides. Next slide. So first, what does this person first language mean? Person first language refers to a specific way of how we talk and write about people with disabilities, diseases, and health conditions. This can be used for a variety of different terms that we'd like to use. Person first language is that we use the person's pronoun first, and then we add their disability or identifier, such as ID, and this could be any other medical condition or neurodevelopmental disability, among other things. The opposite approach is called identity first language. And I really wanted to specifically point out that this is used within the deaf community and the autistic community. And so the way I wrote it was that I used the word deaf first, and I used autistic first. And so that's the opposite approach. It is not necessarily a one size fits all. During our presentation, we are going to use the term parents with ID or intellectual disabilities rather than intellectually disabled parents, just to help convey that their disability is only one component of who they really are. Person first language really identifies with the human first, and that we have maybe an added component to our human experience. Next slide. Plain language is a term that can be used to describe, again, the way we write about things or the way we talk about things. And we really want plain language to be used to help parents specifically find and understand information that they need and be able to use it. Plain language has a long list of guidelines that you can find at this link, plainlanguage.gov. It goes through a really in-depth explanation of what this is, but essentially it means that we're going to be as clear and concise as possible. I'll pause and just direct your attention to the chat really quick. Maggie has dropped in a PDF. If you download and open that PDF, that is all of the links that we have included in our PowerPoint today. Eventually, this PowerPoint and training video will be uploaded to our NAU website. But in the meantime, you can access this PDF and kind of click along as we're going through the training. Next slide, please. So what is an intellectual disability? This is a plain language version of a definition that having an intellectual disability means that it can make it harder for someone to communicate, learn new skills, or take care of themselves. People with intellectual disabilities may need extra support to live, work, and participate in their communities in which they live. Next slide. On the flip side of that, this is the definition of intellectual disability from a very medical lens. It is a diagnosis within the Diagnostic and Statistical Manual of Mental Disorders, or sometimes known as the DSM-5. This is what some sort of doctor or health professional would use to actually diagnose somebody with intellectual disability. And intellectual disability refers to it, or I'm sorry, includes three characteristics. So one is a deficit in intellectual functions. Number two, a deficit in adaptive functions. And that number three, the onset of these deficits occurs during the developmental period, or what they consider before the age of 22. And so it refers to the brain development from birth until the age of 22. Next slide. I wanted to break down intellectual versus adaptive functions. So intellectual functions include reasoning, problem solving, planning, abstract thinking, judgment, and learning. These are also known as executive functions or using kind of this frontal lobe part of your brain. And it's all the processes that we do in order to make decisions and think about things in a certain way. Adaptive functions relate a little bit more to how we use those skills in real life. Adaptive functions include gaining practical knowledge, communicating with others, judging and perceiving social situations, personal care or personal hygiene, the use of money management, and how do we organize tasks that we need to do. Next slide. So intellectual disability, or ID, is the term that at this moment in time is most used by medical, educational, and advocacy groups to describe this diagnosis or this condition. Other diagnostic labels that you may hear are something like intellectual developmental disorder, or IDD, or also disorder of an intellectual development. So if you're seeing ID or IDD, they're referring to the same concept. In the past, medical doctors have used the term mental retardation, and I believe that came to be about in the 1950s, although this was legally changed in 2010 under Rosa's Law. Next slide. I wanted to be able to give attendees a little bit of historical perspective and background. And so Rosa's Law came about, and it was inspired by a little girl named Rosa Marcelino. And this is an image of her on the right when she was younger. In 2009, her family began to advocate for changing the way that the federal government used language. Up until 2010, when this law was signed into law under President Barack Obama, the term in legal documents like individualized education plans at school, individualized family service plans to use by early intervention, and any other federal document, the term mental retardation was used. This was a huge moment and really shift in perspective of how we use language and how the self-advocates of the intellectually disabled community would like to be referenced. Next slide. So I really wanted to give you a little bit of component too about the whole concept and movement behind ending the R word. R is implying from the word mental retardation. And that is something that was used as a medical diagnosis and then quickly became a derogatory term. It was quickly used as something that we refer to people who maybe are less than or not as competent. And it really was hurtful to many people over many, many years. And so Spread the Word is an organization that really took on the idea that we can end the use of the R word and that there are more appropriate and kind words to use in any setting. So they really focused on the R word, but they also have focused on, or they've also kind of evolved and started focusing on inclusion in general and how language changes over time. And they're a great resource for learning a little bit more about what self-advocates would like to use in this moment. All right. So next we're going to talk about some common myths that we may have heard or we may ourselves believe, or maybe they're a little bit more ingrained and we haven't quite addressed them yet. But myths about parents who have intellectual disabilities include that they can't be good parents. Another myth is that if they have children, their children are going to have ID or intellectual disabilities. People with ID are not going to be able to work or contribute to society, as well as autistic individuals always have an intellectual disability as well. I wanted to put like a big slash across the slide, but then I wasn't sure if people would be able to read it later on. But these are all false. And they've all been proven incorrect. In fact, that people with ID are great parents and that they want to be good parents, that they have children who don't have intellectual disabilities, that they are able to work and contribute, that they find a lot of meaning in being in their community and offer a lot of value to our community at large. And then I guess to disarm or to kind of go over the last bullet point, autism does not necessarily mean intellectual disability. Sometimes that can overlay, but that is not a key feature of autism. And so that's kind of a little bit separate, but I just kind of want to make a really clear point about that. Next slide. Okay, before we dive into this gets a little heavier. Any questions or thoughts from the audience? I'm going to take a sip of water real quick. All right, let's dive in to some really significant challenges for parents with intellectual disability. And these are child welfare issues, healthcare issues, pregnancy issues, and the concern for adequate parenting support. Next slide. Oh, so child welfare. So parents with disabilities, any sort of disability, and particularly parents with intellectual disabilities are reported to the child welfare system at a much higher rate than non-disabled parents. There is no evidence to show that these higher rates are truly due to an increased need for involvement among parents with disabilities. And another way to say that is that when people look back at these cases, there's not a true reason for child welfare to be involved, except that somebody had a concern about the parent's ability to maybe learn something or remember something, or kind of going back to those key features of an intellectual disability. Parents with ID also experience higher rates of removal of children from their home and termination of parent rights. This is also well known and very well felt by the community of parents with intellectual disabilities. This is not something that people are not aware of. And I wanted to make that really clear and drive that home, that it seems very prevalent within the community of parents with intellectual disability. There is a true and real fear that who they interact with may report them and may take away their children. Next slide. So why is this happening? So first, parents with disabilities are much more likely to interact with medical and social service professionals based on their own disabilities, based on the needs of their children. And all of these medical and social service professionals, like most of us in this room today, are mandated reporters. So we see something, we're concerned, we are mandated to report what we've seen and kind of initiate that report sometimes. There are really unfair practices within the welfare system. And I guess I'll use welfare because I think that's the most common term nationally. In Arizona, we often know it as the Department of Child Safety. There can be limited interventions that are appropriate for parents with disabilities. And so then when we are attempting to support parents, it's harder to adapt or modify those interventions that we'd use with other parents. And so then we come to the conclusions that maybe those parents weren't listening, aren't able to do it, are not competent, not following through. And then we start to kind of become concerned that can they actually parent well? Assessment practices as well do not consider what parents with ID may need in order to access resources or support. And so when we assess an individual, we're not assessing necessarily their intellectual capacity, and we're not really taking into account maybe what they might need in order to effectively parent. There can also be a lot of bias among child welfare workers and child welfare workers that may not have the time, the resources, the support, or even a lower stress level to be able to learn more about the families that they're interacting with. Next slide. This is a map of the United States, and this is a map showing how parental right termination can be decided and based on disability. So the main takeaway from this map is that if you look near Arizona, Arizona is in green. And so disability or intellectual delay is included as grounds for terminating parental rights. And it can be used as a standalone concern. So within the state of Arizona, if a parent has an intellectual disability, they can have their parental rights terminated on that fact alone, which is scary for parents. Next slide. All right, so moving into a little bit more of healthcare and pregnancy, individuals with ID face healthcare disparities themselves. Healthcare can be really complicated, really difficult to manage from multiple doctors in multiple locations, different ways to check into appointments these days. Following up are different for different facilities. Understanding insurance and how insurance is covered or not covered. It's very, very complex, and it can be hard to manage and hard to navigate that landscape. Access to birth control is also much more complex for people with ID. There's limited information that's accessible that talks to parents who regarding different birth control options, that talk about the side effects of birth control, and even the frequency of use. How often do I need to be obtaining this birth control in order for it to be effective? Women with ID are also at an increased risk for abusive and controlling relationships that may limit their ability to access birth control. In the past, people with ID have been sterilized against their will and against what they wanted. So there are many layers to why healthcare and pregnancy might be complicated. There's also barriers to going to a women's reproductive doctor, like an OBGYN, and pediatric visits. Those well child checks that happen after a child is born are really frequent. I think the first one is 2 days after, and mom is expected to get there on time with a newborn baby, remember the visit, and that can be a lot for any new parent, let alone all of the other challenges that are going on, that you've just given birth, that you've just kind of gone through this really big experience, that you're learning how to take care of a newborn. So there's so many layers there too. Next slide. And then parenting support. So this is kind of it's really about the lack of parenting support that parents with ID feel. Parents with ID are feeling isolated. Like I said before, they're navigating multiple systems, which can be really challenging for any parent. A really huge fear of child welfare involvement. This fear is real, and parents with ID, when they meet medical professionals, it seems, the things that I've learned, it seems like that's in the back of their mind. What do I do or say, or what should I not do or say so that I don't get reported? They can often feel judged by professionals, like someone is dismissing them, someone is not thinking that they're competent, that can be really challenging to build trust and rapport. And that really parents with ID can learn new things just like any other parent. It might take a little bit longer. It might look a little different. We may need to change it into a more accessible format, like a visual format, like a handout or a video. But it's our job as people who go into the home and people who support parents to try to kind of start figuring that out and try to start problem solving that for ourselves and see what might work best for the parents that we're involved with. Next slide. So these are just a few implications for home visitors. We're really diving into the nitty-gritty bits of these in our next 2 training series. But really, first and foremost, we want home visitors to take away that we want you to start building the relationship first. And maybe you are already starting to do that. But if you feel like you have a parent in mind or a family that you're working with that like, gosh, why is this just not going well? Maybe stepping back and coming back to building rapport again with that family and focusing on the relationship. This is easier said than done, but being patient and taking more time with these families. So I fully recognize that many home visiting programs have kind of guidelines or expectations for caseload, for when you should be getting this curriculum taught and how long it should be taking. And I think if there's a way to feel supported by supervisors, or there's a way to be a little bit more flexible, figuring out those ways to do so. Really focus on strengths. Again, if you're having a family come to mind, think about what that parent is doing really well and try to start there and see if we can replicate it with something that might be challenging. Presuming competence. This is something that we'll talk again a little bit more in depth for our next training. And this is the idea that simply we assume that the parent of a child is competent in every skill and that we are equal and that they have just as much to offer us as we do them. Finding resources. There are not many resources to help support parents with ID, but they are out there, and our 3rd training will really list all of the resources that we have found valuable and that we find interesting and useful. Last but not least, individualizing care. And I'm going to go ahead and go in the next slide because I gave a little bit more time to this. Thank you. And I'll go ahead and read this quote and we'll talk a little bit more about it. Though all people with intellectual disabilities share the diagnostic criteria for slower learning, longer processing time, and increased support needs in daily life, each person's skills and interests are unique. The needs vary widely, and the only way to be effective in supporting parents is to learn what their individual needs are. And I think this is the main topic of our next training, is that how do we do that? So we've learned a little bit about the broad shared characteristics and diagnostic criteria. And now how do we really go into a family's home and understand how to support that family where they're at and with what they have concerns about? All right. Any questions before? That's kind of wrapping up all of the learning component. And now we get to jump into having Krista share any other questions or thoughts about all of the content before. All right, well, this is the fun part. I will turn it over to Krista. Krista is a augmentative and alternative communication user, which means she has an AAC device that she will be using to answer questions. And I just wanted to highlight, these are pictures of her and her son that she shared with us. We have a list of questions that we'll go through, and then we'd like to open it up to attendees to ask any questions after that.
I am Krista. I'm going to be a speech language pathology assistant. I like to help people out and change lives. I like to present at conferences with augmentative and alternative communication AAC. I have a son named Michael. He is 13 years old. I am a single mom with help from my family. He plays football and he is going to high school next year. Oh, May. I do have help. Parenting takes work. He is doing well in school. He loves to go on vacation with my mom and I. It is wonderful, but it is rewarding and fun and most challenging too.
Next slide.
I did my URT think I was going to be a parent because of my disability, but I got through. Honestly, he is 13 years old now and he is a good young man now. We as a family are working it out. However, if I do need help, I have to be careful of child services because I am scared that they will call child welfare and he would be taken away. So I would get home services again, but I had to get support from my brother Tyler first. Tyler helps provide a role model in talking to Michael, and he spends time with us. Tyler also gives parenting advice. He is a good little brother. Yes, I had home visitors, but it was not always a good experience. Honestly, one of the women judged me a lot. For example, she made comments such as a circumflexion, you do not want that for him because he is not. She overstepped and told me how to be a parent. I also think that she called child welfare. I had a lady before that and she was like an amazing woman and she gave me advice. She was helping me through the toddler stage, but she had to leave. You need to understand that parenting is not easy for everyone, not people with disabilities. Do not judge us, but give support if needed. How amazing I was holding and feeding and diapering Michael with only one really functional arm. They should look for the successes as well as things people could do better. I set up quick talk pages on my device so that I could respond to Michael promptly. And you set up game pages on my device when he was older.
I think that
Do
might be
you,
the, oh,
do you have questions?
Krista, excuse
Thank
me.
you.
I have a question for you. Um, sorry. So I was wondering, I know you like to spend time with Michael and you've gotten to see him play sports. What other what are some of the challenges you have now raising a 13-year-old?
His attitude.
His attitude. I wonder if any other parents could relate, right? Great, thank you.
And people think, he was my brother.
Oh, how does Michael respond to that?
He said, no, she is my mother.
Good for him. Yeah, as you would expect a young man to do. Huh? That's great.
His football coach.
His football coach thought he was your brother? Oh, wow. Oh, good. Nice. If you were if you had a young child, I won't say a young mother, if you had a young child again, and what kind of support from home visiting programs would you want to have? Would you like to have?
Parenting.
Mm-hmm. All parents need help, don't they? I know I do.
Yes.
Great. Wonderful. Anybody else have any questions? All right. Thank you, Krista. And for sharing. That's not always very easy
Thank
to
you.
do. Thank you. Oh, wait, there's a,
Yeah, we appreciate you being here and taking time to do this.
yeah, you're getting a lot of thank yous in the chat. All right.
Well, we
Nicole,
we
do
might
you want-
have a little, yeah, we might have a little extra time. Before you click on play, I just wanted to give a little background. This was a video completed in 2009, I believe, and it was with a group called Parent to Parent New York. And so both of these parents are with ID and are speaking to their experience, and one is kind of interviewing the other parent. And I just thought they really touched on some concepts that we talked about today. And Sarah, once you hit play, do you mind hitting the closed caption button too? Oh, we don't hear it. You know what? I didn't think you might need to reshare with the audio.
Yes, let me stop sharing.
Yes.
Thanks, Krista. Yeah, if anybody can help me out. Share sound, right? Optimize your video share. All right, are you seeing the correct screen now?
Yes.
Do you think they might learn
Yeah.
it? What do you
Hear
think
it?
they might learn?
I
Yes.
think if we could educate everybody about people with disabilities can be wonderful parents too. They might just do things a little different to achieve the same objective as able-bodied parents.
So do you think parents who have disabilities care as much about their kids?
Yes,
You
I
do?
know. I know, because my whole life changed when I had my first son, and my second son was totally unplanned. So,
Oh, there's something unique too.
yes, and it has, being a mother is the best title I personally have ever had.
Yeah.
So I'm going to do my best at it.
It sounds like one of your best supporters was your own mother.
Yes, I had a very supportive mother who, there was something she didn't think I could do, but instead of telling me not to do it, she said, you figure out a way to do it yourself. And 9 times out of 10 I did. So I really, without her saying go ahead and try it, I wouldn't be where I am today.
One thing that Aldia had told me is all too often, even coworkers treat her differently. Well, you used the word they treat you like a 2-year-old.
Yeah.
And even though you were, quote, peers working side by side. And
I was working once for a day treatment facility, and because I had the degree, I was a supervisor over a couple women, and they could just not handle the fact that I was their supervisor working in an agency for people with developmental disabilities. So that
tell me
was
a little
really
bit
tough.
about what you've developed as far as a
Well,
prevention
sometimes when
plan.
I get nervous or I get excited, I have a problem communicating. So when it's time for me to call for the help I really do need, I need to be able to tell my story. So instead of relying on my voice to tell my story, I've created a document to tell my story. And within the document, it will have a history of the family life, who's in the household, the ages of the people in the household, the cognitive levels of the people in the household, so that the first responders or the people coming into the situation can read the document and know exactly where we are at that point in time without having to rely on my voice or my husband's voice. The document will tell the story.
That's another one of the parallels of our parent-to-parent program, and one of the things that we've created is called a healthcare record-keeping notebook for similar reasons, because there's different times where that's needed. But one of the pieces in it is directions to your home, because for the same reason, when you're in a crisis, the last thing is you can't speak coherently or think coherently, and there you can just hand it over when there's a crisis happening.
And if you think it's that difficult for able-bodied parents, just think how more difficult it is for disabled parents with speech impediments or cognitive limitations. So this document could be their voice.
And yes, and someone else's assumptions
Yes.
when they're coming into your home.
I actually had somebody from social services, somebody in the neighborhood hotline me. Social services came to the door. She had that look on her face, like, I'm gonna get you. She saw my kids and she realized it wasn't me. She took the time to figure out
Well, that's,
it was a behavior thing with the kids. It wasn't neglect on my part. But not all social services or police or firemen think that way. So this document will help them think that way.
and you raised the point, your fears are real.
They're really
Your
not about
fears
what
are
happened.
real.
Losing my children. Somebody would come to help me because they got the call, come and see that I needed help. And instead of talking to me and finding out what I need, they would assume that the kids belong in foster care and I belonged in a program somewhere. And that's what my fears are, is, because I've been very successful living independently with no programs.
Right.
The last thing I want is a program. Although they work for other people, they don't work for me. So my fear is if somebody came to the house, got the right impression, the kids would go to foster care. That's what I would like to do. I would like to start awareness, educating people about how easy it can be to support parents with developmental disabilities.
And the one thing that you were saying when you first started talking is that feeling you feel of isolation and thinking you're the only parent going through this, and that's another, so much the same as our parent to parent, is when any other parent finds out about their child, they think they're going through it alone, and that's really what you want, is to make sure others don't go through it alone.
Exactly. Thank you.
Thank you. I think that these two women had a wonderful sense of humor, but really spoke to the fear involved in parenting, limiting, wanting to limit interactions, but also starting to tell us of really concrete ideas that they used to help support themselves and keep them, their family safe.
I like it, I agree, and I have her experience too.
Mhm.
Thank you.
Yeah. So any thoughts on that video or comments about today? Anything that you want more clarification on or understanding or more information? Well, I'm not seeing anything. Thank you, Krista and Nicole. That was really, really wonderful. I think it was a great start to these trainings. We have 2 more coming up. The next one is going to be on October 15th at 12 o'clock Arizona time. And that's about the individualization of care. And Nicole kind of alluded to that today, but just kind of talking about how we can meet people where they are and become attuned to what they need and really work with them in a way that is more helpful. And then the third training will be our last in this set of trainings, and that is Tuesday, October 29th, again at 12 o'clock Arizona time. And then we'll be talking about tools and resources. So Nicole has provided, and Krista have provided a lot for us today. You've gotten a handout in the chat. And actually, Maggie, would you mind, who is she? Or I don't know if Michelle or Nicole, if you could put that in the chat again. I think Maggie had to leave for class. But for those who've just popped on at the end here, we have a handout that was in the chat. And if not, we can email it out. But it is a list of all of the different resources and agencies and ideas that have come up today with their websites and the links. So that might be a place to start right now. So thank you for putting it back in the chat for us, Nicole. And then last but not least, oh, go ahead. Sorry.
Oh, can you go to the next slide, Sarah?
Yes,
please?
that's what I was going to do.
Please.
Yeah.
Okay. So, hi everyone. Again, thanks so much for attending this session. I am going to put in the chat, as well as you could use your phone to scan this QR code. We kindly ask that you fill out this survey. This survey is for our funders to gather information about how helpful this feedback was, and more importantly, how we can improve our trainings for you all in future sessions. Also, if you need a certificate, this is the place to go and fill out the survey, and then you'll be directed to an electronic one as well. So thank you again. And the survey should take you like less than 5 minutes. It should be pretty quick.
We would love to hear any ideas you all have or any comments, challenges. We're really hoping to build this into something that we could do more often, or maybe cover more topics if there's specific things that you'd like to know about that. So all the feedback you can give us, the more the better. And we'd really appreciate you taking the time to do that. So about that, I'll leave that on in case anybody else, but that's the end of our training today. We really want to thank you all for joining us. Thank you, Krista. Again, it was really important for you to be here. Thank you, Sarah. And Nicole, we really appreciated both of you and your presentation today. So if anybody else has questions, you can stay on. Otherwise, have a great afternoon and enjoy the rest of your week.